my topic was corneal perforations. What are the management modalities? Whether you are a cornea surgeon, cornea specialist, or general ophthalmologist, corneal perforations we keep seeing, and we have to understand that we should learn to manage these corneal perforation. It's not very difficult. So I'll just go through all the modalities that we have. How do we choose that? All those things, and I'm sure that you'll be able to do it yourself. So if there's a perforation, that means there's a loss of corneal tissue. If there's a loss of corneal tissue, the replacement by the corneal tissue would be ideal. So that is an ideal case scenario. But we know cornea is an allogenic tissue, so there will be rejections. And if you, for a small perforation, if you do a lot of suture, then there will be suture-related astigmatism, suture-related infiltrates, and all those things. For smaller modalities, the people around the globe, they had been thinking of different modalities, how best we can, seal those smaller perforations. So these are the all main four modalities of managing perforations. One is cyanoacrylate glue, and popularly known as TABCL, or tissue adhesive bandage contact lens. Second is multi-layered amniotic membrane grafting. Third is tenon patch graft, and last is lamellar corneal patch graft. So how do we use this? How do we perform these procedures? And how do we do a decision making? How do we choose which one to be covered? So let's go one by one. So I'm going to tell you how do we perform these procedures. So first is cyanoacrylate glue. This, to me, every ophthalmologist must know. And this is a very, very, very no rocket science. And you all, if you can do a phacoemulsification, you can easily do a cyanoacrylate glue. It's not a big deal at all. This is and very cheap, easily accessible. It's very easily it's available, and you can get that. And it is helpful in managing a smaller perforations which are less than 2 millimeter in size. So I'll just take you through this video and to know that how do we actually do it. So as I just said, the cyanoacrylate glue is easily available, and these are just like, we have Fevikwik, those kind of substance or compound it is available in this ampule, which you break and aspirate into this to 1 cc syringe and place a drop on a sterile place. So this is the Merosol sponge cover that I'm using. This is a patient who has a very small perforation around 2 millimeter size. If you do a CDLs, you can see that CDL is positive and the aqueous is coming out. You can see over there. It's a very small perforation. So there are two very important steps. One is removing the epithelium around it. So wherever the perforation, at least 2 millimeter around, you need to remove the epithelium. If epithelium remains, then it will not stick. Then backside of the Merosol sponge, you just tap into this glue, and then you do 2 more taps on so that the excess of cyanoacrylate glue remains there. Dry it. Drying again is very important, and then you just touch it, and within second it gets polymerized. So 2 important steps are removal of epithelium and making the surface dry. Sometimes there is perforation which cannot be sealed on slit lamp, and because it keeps on leaking. In those cases, you can take the patient into OR, inject an air bubble, and so that the air bubble will plug it from back, and then you can use your cyanoacrylate glue. But sometimes, like in this patient, you have a fistula. So even with air, you cannot plug it. So, then what you can do is you can use a part of bandage contact lens or this sheet. This is a sterile drape that we generally use. So I've just placed it over it so that for the time being that aqueous stops coming out, and then you immediately place a cyanoacrylate glue, and after removing the epithelium, 2 millimeter epithelium around it. And after that, you place a bandage contact lens. Bandage contact lens here we place so that patient doesn't get irritation. So it is not that the bandage contact lens gets glued over there. It's just so that otherwise it's quite irritative and the patient gets a lot of irritation. You can see the same patient with the air bubble. You can form the AC if there is a continuous leakage. Otherwise, what we generally do is do it on a slit lamp, make patient wait for an hour or so, and then again you'll see some aqueous coming, some ACS starts forming, and then you can send them off. How it works? So if there is the upper cartoon shows there is a perforation, and then you make a bridge. You make a bridge over the perforated side with cyanoacrylate glue, and then the epithelium under it. So where there is a perforation, there becomes a pseudomembrane. There comes a pseudomembrane, and that pseudomembrane slowly it gets resolved and forms a scar. Epithelium comes, and when the epithelium grows under this cyanoacrylate glue, this glue gets loose, and then it falls off. Generally, we keep this cyanoacrylate glue for good 2 to 3 months. sometimes even more. That depends what is the underlying pathology or underlying etiology, and you have to ensure that the underlying etiology or underlying pathology is taken care of well. Cyanoacrylate glue, it attracts blood vessels also, so that again is useful when you have perforation secondary to any infection. It has some antifungal antibacterial properties as well, that again is helpful when you have infection and then you have a perforation. As I said, how do you follow up? You keep on treating the basic pathology or basic etiology, and when you don't be in a hurry to remove it, because there's a chunk which is sitting over there, when it gets epithelialized, it will come off on its own. So what you can do is, maybe after 2 months or so, you just see with a Merosol sponge, touch it and see if it is easily moving. So if it's moving, then only you remove. If it is not, let it be. Regarding the bandage contact lens, keep on seeing the bandage contact lens every 2 weeks. If there are any deposits, better to change the bandage contact lens, or else at least recycle it. That's how we follow up the patients who have undergone cyanoacrylate glue plus bandage contact lens application. So this was about TABCL. The next modality is multi-layered amniotic membrane grafting. So how do we do multi-layered amniotic membrane grafting? So this patient had pterygium surgery elsewhere along with MMC, and then he had this perforation, which is at least 1 millimeter by around 3 millimeter. And this patient had undergone a multi-layered AMG. This is a very old video. I think it's more than 10 years or so. So in those days, we used to fold it and suture it. So what you can do is, what I'm doing here is folding the amniotic membrane over twice. So, and then I'm suturing on the side, and it works very well. And the best part about multi-layered amniotic membrane grafting is it provides some volume as well. So if you have loss of tissue, it helps in that. But it's important when you're doing this peripheral perforation, if you can pull the conjunctiva from periphery and cover that, so that it provides the blood, and it stays well and it heals very well. You can see the same patient who had undergone multi-layered AMG plus conjunctival graft. We have just pulled the conjunctiva over it, and you can see it worked very well. And then later on had cataract also, that was also been taken care of. So how it works, it fills in the gap, it fills in the volume, and then which slowly, if the basic etiology has been taken care of, I'm stressing it again and again that it's not that you have just sealed the perforation, job is done. No, we have to ensure the basic pathology is also been taken care of. So what it does is it fills in this gap, and slowly that area gets merged with the stroma, and as you can see, some gap is also been filled. So another patient who had undergone multi-layered AMG, you can see nicely healed and could tolerate phacoemulsification as well. So this patient is a neurotrophic cornea. You can see the graft penetrating keratoplastica, and there was a perforation bang in the center. So this patient had undergone amniotic membrane grafting, multi-layered amniotic membrane grafting. This was by using a fibrin glue. So what I'm trying to do is I'm placing a small piece of amniotic membrane. I'll stick it with fibrin glue and then place 1 or 2 more layers over it. So once you have seen here, again, you have to ensure that epithelium surrounding some epithelium is removed, so that this amniotic membrane can be spared. So I'm quickly placing my fibrin glue so that the aqueous stops coming, and then over it, I'll just place this amniotic membrane. So as we are going to use a multi-layer, so you can use 1 layer or 2 layer or 3 layers, depending upon what is the tissue loss and how much tissue you want to fill in. As you can see here, this is one portion. So I'm just removing slight epithelium in the periphery so that I can place another amniotic membrane layer, and that can be again glued using the fibrin glue. Fibrin glue again has been very helpful, and ever since the fibrin glue has come, we never do sutured amniotic membrane graft. You can even use it sequentially. Like what I'm doing here is I'm reconstituting it over the surface. Initially I had placed a thicker one and then the thinner one, and you can store this fibrin glue both portion in your incubator, and you can use it for sequential patients as well. So this is again one of the patient who has undergone, and this patient had undergone tarsorrhaphy as well. Again, for neurotrophic corneas, tarsorrhaphy works like magic. So you can see the nicely healed perforation using multi-layered amniotic membrane grafting. Third is tenon patch graft. This was described from RP Center, and Dr. Namta Sharma is already here. She has published and taught a lot of people, including me, how do we do a tenon patch graft. So you can see this patient again. This patient also had a pterygium surgery, and following which there was a med. So this patient was managed by tenon patch graft. So I'll just show you again. Tenon patch graft is, it's not that you have to depend on amniotic membrane grafting. You have to depend on amniotic membrane. So you have to find out, or you need some fibrin glue as well. Tenon patch graft you can easily do, even a general ophthalmologist can do, because you don't have to depend on amniotic, or you don't have to depend on any eye bank. So what I'm doing here is procuring the tenon patch graft. So it is very important to have a good dissection. So I'm just separating the fibers above tenon, and then later on I'll separate it below the tenon. So I'll dissect the fibers above and below the tenon. So here you can see I'm just procuring this tenon. So I've already dissected, and you can choose. I've already marked what is the size of the tenon that I want to use. So I'll just place it over the perforation area. So here, what we generally do is make a small tunnel all over. So I'm just removing some epithelium. I'm using a crescent knife and making a tunnel all 360 degree, very small, around 2 millimeter, because this gives us an area where you can tuck your tenon graft in. This is not a necessary step. You can simply place it and place a compression suture over it. But what I have found is this: if you make a small tunnel, it really helps, so that you can tuck this periphery of the tenon tissue in this particular tunnel. So as you can see, and then I'm just placed this tenon graft that I have procured from inferior conjunctival area. So I'm just pushing it into that tunnel that I have created. I've used fibrin glue. Again, fibrin glue is not a necessity. You can just push in and place a compression suture also, but with fibrin glue, it sticks really well. Now I'm using a compression suture. So I'll take two sutures, make this the figure of 8. What I'm targeting, or what I'm aiming, is this cross. This cross should be at the center of your graft. You can place 2 8 sutures also, 1 8 suture also, depending upon the size of perforation, and also depending upon how big a tenon graft you have taken. And at the end, you can just inject some air bubble, the area from where I had procured my graft. So I'm just closing it using a fibrin glue. So the surgery is over. I'm using a bandage contact lens as well. So you can see this patient who had done very well. We have done, we started doing tenon patch graft, I think 1.5 years back, and we do more of tenon patch graft and less of multi-layered AMG for perforation, which are more than 2 millimeter in size now. The last modality is lamellar corneal patch graft. Sometimes, this patient had autoimmune melt. And this patient, you can see even the surrounding cornea, there is a perforation in the center, which will be around 3 into 1 millimeter, but there's a region of close to 6 millimeter, which is really irregular and has a significant collagenolysis surrounding this perforation. So you can see this cartoon. So what I'm going to do is remove the disease, the surrounding the eaters tissue as well, and then I'll fit my lamellar patch graft into it. So I'll just take you through this small video. So what here again I'm doing is my aim is to remove all the diseased, that necrotic tissue. Here again I'm using a small tunnel all over, and then it will give me an area which to demarcate which is diseased and which is normal tissue, and that I can always cut. So I'm just preparing the host area, and then after marking, so I'm just marking it on the Teflon block, so that I take only that much dimensions. So I'm using a 15 number blade to cut it. So this is the rectangle that I'll have of same size that there is the perforation is. So this I'm going to use over here. Or now I can suture it with one suture, just like we use our hand fashion graft. So I'm just trimming it in the periphery, and then I'll just quickly take you through this video. Okay, so I've placed one suture. So first suture is important, that is a stay suture, and after that you can keep on seeing where you want to take the next suture. So this is the first suture, which is very important. Then I'm taking the second suture, and then again, wherever I feel that, if it's slightly more, I can always hand fashion it. So I have got an initial dimensions, but I'm hand fashioning it according to the size that I need and the shape. Even, on the one left side, you can see it's slightly straight. On the right side is slightly curved, so I can hand fashion it the way I want, and then, place routine sutures, and then bury the sutures and place a bandage contact lens over it. So this is the same patient, and the patient is on systemic immunosuppression, strong systemic immunosuppression, and he's doing well. This is, I think, more than now. The patient is now more than 2 years into this surgery. So this was about how do we do a corneal lamellar patch graft. Sometimes, you have such bad collagens, such big perforation. So we don't have to think anything. If you are not a cornea surgeon, take a cornea surgeon help and straight away take the patient for full thickness penetrating keratoplasty. So there's no discussion on these kind of cases. So the 4 modalities that I have shown you, now you know how to use it, how to use cyanoacrylate glue, how to use multi-layered AMG with sutures, with fibrin glue, how to perform tenon patch graft, and how broadly you can do your lamellar corneal patch graft. But how to choose which cases, which modality to be, chosen. So very important is detailed examination before you proceed. What all things you see in the examination. 4 main things. 1, size of perforation. Less than 2 millimeter. Is it 2 to 5 millimeter or more than 5 millimeter? Location. Where is your perforation? Is it peripheral or central? What is the etiology of perforation? It's infection. It's ocular surface disease. It's an autoimmune melt. Logistics. What do you have? Where are you practicing? What modalities do you have? It will depend on that. It's a very busy slide, so I'll just take one by one. Size of perforation. If you have less than 2 millimeter size, you easily can use tissue adhesive, and if you have infection, you can use and easily use tissue adhesive, and that's work very well. Having said that, you can use tenon patch graft and multi-layered AMG as well, but the first modality of choice will be TA BCL for perforation less than 2 millimeter in size. If you have slightly bigger, maybe 2 to 5 millimeter of perforation, then tenon patch graft does very well. The alternative is multi-layered AMG and lamellar corneal patch graft, but you have to be tenon patch graft. As I said, we started doing it 1.5 years back, and now we do more tenon patch grafts than multi-layered AMGs. If you have more than 5 millimeter, don't think anything. Straight away, you have to replace the corneal tissue, be it lamellar form or full thickness. That depends on the corneal, what is comfortable with and what is the etiology. So this is based on size of perforation. What is the first treatment of choice? Second is location. So if you have a peripheral one, you have an accessibility of the blood vessel. You can always pull some conjunctiva also. So you can easily place a multi-layered AMG and pull some conjunctiva. You can do a tenon patch graft as well. For central, you may avoid multi-layered AMG and preferably use tenon patch graft. So because it's more of physiological tissue. And then very important is etiology of perforation. Why that perforation happened? Infections. So in case you have infection, I've already discussed TABCL, TABCL, and TABCL. So if you have infection less than 2 millimeter or around 2 millimeter, you first choose TABCL. You can, having said that, you should avoid AMG because AMG is a biological tissue and it might increase the multiplication of the organism. You may avoid tenon also because there's infection, so there is inflammation going on. It might eat it away. TA would attract blood vessels. I have already said it has a antimicrobial property, so TA would be preferable when you are dealing with infections related perforations. Suppose you have ocular surface disease like Steven Johnson syndrome. Here the epithelialization is a big challenge, and it's better if you can again use a TA. This again attract vessels, help in resolution. We do see perforation in SJS, again is very, very challenging, but what we have found is TA works very well, but you can use a tenon patch graft as well. Sterile melts like rheumatoid arthritis, again tenon graft will be very great. It works beautifully well. TA can also work here, but there is a sterile melt, there's a big Delen over there, so it cannot fill in that gap. So for that you need to use either multi-layered AMG or tenon. We like using tenon patch graft as I've shown you in one of the cases. Consider if you want to use, sometimes you have to combine, you have to use tenon along with AMG over it. So these are basically done in OSD cases where epithelialization per se is challenging. So in those cases what we generally do is we do a tenon patch graft and over it replace an amniotic membrane graft as well. So you don't need to get confused. I'm just trying to tell you that there can be multiple options for one particular perforation as well. And that again depends on logistics. Where are you practicing? What all techniques do you have? What all you know? What I feel is you must know whether you are general ophthalmologist, cornea surgeon, you should must know TABCL and tenon patch graft, because these are not difficult surgery as well. Sometimes patient cannot go to OR, he's not fit, or some of the other logistic issue. TA will be very handy. So we need to understand that although this is a broad guidelines, but you need to stay flexible. Sometimes one modality fails and you might need to use another modality also. All said and done, you have to check and address the etiology. I'm again emphasizing it, unless you take care of the primary etiology, primary pathologist, it will not help. Doxycycline, we all know it works for collagen lysis. So whenever there's a collagen lysis, I tend to prescribe doxycycline 100 mg twice a day. So I already said you have to look for the etiology. So to conclude, cyanoacrylate glue, multi-layered AMG, 10 patch graft, these things these are the main modalities, non-corneal transplant surgeries, and depends on the size of perforation, location, etiology, and logistics. You need to stay flexible and keep on underlying the underlying